going to do just a few images because it's very hard to talk about the thumb for me without being able to see it. And then we're going to examine the thumbs we have available here and see what we can learn from those. So I should disclose to you that I was a design consultant to the design of the Push Metagrip, which is the name sold in the USA. In the rest of the world, it's the Push Ortho Thumb Brace CMC. And our company does currently sell that in the US, so you should be aware of that. In the clinic, we depend on the physician to determine the diagnosis. And one of the ways in which a physician does this is to determine the pain response to certain tests, right? The grind test, you know, there's a long list of them. I'm not going into them. But we as therapists, I think, have a different responsibility. We should certainly determine if the diagnosis is accurate, and we all know that that depends on the source of the referral often, because if it's a specialized surgeon, it's usually more accurate than if it's from a general practitioner. But our job is to look at the pathological pattern and determine the specific treatment. If you are in a clinic where every patient who comes in with CMC osteoarthritis gets the same approach and treatment, I would encourage you to examine that, because although many patients are similar, our responsibility as hand therapists is to have the skill to determine when that patient does not fit in that norm. Now, let's say you're driving down the road, and we'll say this is in North Carolina where I live. Okay, it looks like this. And you come to a tunnel. What gives you the confidence to drive through the tunnel? What gives you the confidence that the weight of the earth above is not going to fall down on you? It's the arches on the side. They carry the weight from the middle down the sides, and you're safe to drive. You're safe to drive through the tunnel, right? The thumb is no different from this arch. It is carrying a load. It's carrying the load of pinch, and you want that load to go through an arch smoothly to the bottom, to the CMC joint. Because in that position, the CMC joint is at its most stable, or if you will, most congruous. It has the best fit. And therefore, because it has the best fit, it distributes the pressure. When the joint is not in an ideal position, the pressure is focused in one small area, and so it's actually greater pressure per square unit. Now, if you pinch at your fingertip, the force at your CMC joint is a multiplier of 12. So you're turning the key in the door and it won't move. But whatever force you're applying, the CMC joint feels it much more emphatically because it's a stronger force. So our goal of bracing is to balance the load at the CMC. Now, most of us were taught that we make a brace or a splint to immobilize something, right? And we immobilize it because it's inflamed, right? Okay. Well, the thumb CMC joint, it's the type of arthritis that is not, it's not pronounced by inflammation. It is truly more a wear and tear. Yes, there's probably a microscopic inflammation, but we're not talking about a synovial response. So my view is we're not using bracing to ever immobilize the CMC joint. That's not our goal. Our goal is to stabilize it in mid-range so that it's functional and so that the remainder of the thumb is in a balanced posture to keep that load on the CMC balanced. Does that make sense to everyone? Now, that kind of bracing is very different from immobilization bracing. And one of my frustrations with the study that's been done on this thumb brace is their standard was, does it immobilize the CMC joint? Well, no, it's not intended to immobilize it. So it doesn't do that particularly well compared to some others. So it's like they missed the point of what we were trying to be focused on. So our goal is to figure out how the load at the tip can be carried through that same arch that the tunnel has. Now, this is a pretty good looking thumb, isn't it? Yeah. Huh? Yes. Yeah? Okay, I see a lot of yeses. Uh-huh. But what we're looking for is we're looking for the subtleties. So if you really look carefully at this, it's not an arch, is it? It's just off the arch. The MP is slightly flexed, which is what you want, but the IP is extended. So there is no real arch. It's beginning to move into a collapse pattern. Now, try to have X-ray vision. And imagine this green dot is the second metacarpal. That's the index finger metacarpal. Are you with me? This is very important. Okay, second metacarpal. Look where the first metacarpal is. The first metacarpal is not just parallel to, but it has flexed relative to the second metacarpal. I'd like to repeat that because this is probably the single most important point. Imagine the second metacarpal, and when you watch the person, see whether or not the first metacarpal comes over and beyond the first metacarpal. In this instance, it's just a small amount. Does that make sense? But it's headed in the wrong direction and it is imbalanced. What we'd like to see is this, but we don't see it in this thumb. Now, the irony is, Brigitte, as our example, hyperextends her MP and collapses her thumb and has no CMC symptoms. So the symptoms don't always correlate with what you see in the clinic. This person may be asymptomatic. But when you get a patient who presents with CMC OA diagnosis and they are painful at the CMC joint, you know that this offloading, this imbalanced loading, is probably the single largest culprit to causing their pain. So we want to look at the CMC position or the first metacarpal position relative to the second. This is my thumb. My pitiful MP joint, you see there. But what you see is my left thumb initially collapsed like this. And you can see I become very parallel. And this X-ray is not quite, my thumb is not quite in position over my index finger. Okay, so this is a little, the X-ray is a little off on its perspective. But do you see how the angle is different than my first metacarpal? Very different. And I had a hyperextension collapse deformity, which I can no longer get into because for 18 months I wore a brace and I would not allow my first metacarpal to flex at all. I kept it out and extended, and therefore I never went into my collapse posture. And by not going into it for 18 months, I retrained my brain. Because in the brace, I'm using all of my muscles. The brace is not preventing muscle use. But I'm training in the brace because the brace is simply putting me in the position where I recruit the muscles correctly. Does that make sense to everyone? So I'd really like for us as therapists to shift our thinking away from bracing as immobilization. A static splint, immobilizes. It doesn't always have to. It can be a very useful proprioceptive tool, meaning because you're in the brace and you feel your muscles contracting inside the brace, you know where you are. It gives you that feedback loop. So I just arbitrarily chose 18 months. I don't know why. But after that, I now cannot collapse. I have to think about it to even get right there, and that's as far as I go. And I had significant MP hyperextension. So I know it's possible to change pathological patterns, but I was a highly motivated, focused therapist who was interested in the thumb. It's really hard, I think, with the general public because their thumb quits hurting. Where's the motivation to wear anything? I just wanted to include this study because it looked at the kinematics of the thumb, 4 normals, 1 with osteoarthritis, and it clearly shows that when we have the altered biomechanics of the thumb, that it affects the entire upper extremity. We alter how we move all of our other joints. We may not realize that, but we do. So we want to modify the pinch activity. We want to get the thumb in that stable, curved arc posture. We want to alter the pattern during loading. Someone comes into your clinic and you say to them, tear this paper, and you watch them and they stare at their thumb and they tear the paper. That's not reality because they're thinking and they're focused on their thumb. And it is extremely difficult, I think, when you're doing a functional task at all times to be focused on what is my thumb doing. You know, you need to get on with the task, right? So to me, the more important thing is let's construct an environment for the thumb so that each time it's loaded, you know that the right muscles are being recruited. And you know that the pathological pattern cannot be reproduced. That's how you break that cycle. In an adult who has used their thumb in whatever manner for their entire life, you will not change that motor pattern in a short period of time. That's why I felt like I needed 18 months, you know, I'm a bit older. But it has to be long enough to change. And so I think what happens is we treat CMC osteoarthritis, we treat the symptoms, we treat the pain, that goes away, but we haven't treated the cause. And treating the cause or the pathology is a much more difficult, much more prolonged, much more involved. Yes, the dynamic stability exercises that are being studied and that everyone is doing, they certainly have value. But I just think there's a slightly easier way to accomplish this. And my question would be, are patients motivated enough to do those stability exercises enough to really change their pattern under load? And maybe we can see that this afternoon. So, to me, our job in the clinic is first to confirm diagnosis, again, depending on the source of where the referral came. And then we need to determine the disease stage. If someone walks in and they have a clear shoulder sign and you know that they're already subluxed or close to dislocation of the CMC joint, obviously you don't treat them the same way you do someone who's early and has pain but has no other obvious anatomical problem. You differentiate so that you can gauge your treatment accordingly. But then, for me to figure out what I want to suggest to a patient to improve their thumb stability, I want to first manually examine all of the joints because that just tells me where the weak link is. Where is the joint that's unstable? So what do I have to really pay attention to? And most of all, I want to observe loaded pinch. And I gave you the reference of the tear test, which I've found really useful. As you tear the paper, it gets thicker. You put it back together, so it increases the resistance. And the trick is that you talk to your patient as they're doing this. You distract them. They're not focused on their thumb. You just say, okay, tear that paper as fast as you can. Okay, what's the name of your oldest daughter and how is she and what she, you mix it all up so that you see reality. You see what the thumb does when the person's not paying attention, but it's loaded. And that's what you want to change for the long-term good of the CMC joint. So it's these two last ones that we're going to focus on this afternoon. And then the question is, well, okay, what kind of brace or orthosis or splint would be the useful one for this patient. Now, because the CMC flexion is most common, that's where I start, because that's a great process of elimination. But many times that is not the solution. So being able to look further than that is very important. We talked about the dorsal subluxation and being able to determine that. Look at the MP joint. We've already talked about this. Look at the IP joint. And this tells me, I look at this thumb, which is sort of like your thumb, Brigitte, and I say, okay, where do we need to start? What do you see, what comes to your head when you see this thumb?
She's not activating flexipollicis longus and just pulling her index finger towards the thumb to create the pressure.
Okay. And what would your gut reaction be to the first thing you'd want to try?
Sometimes just stopping the hyperextension in the EP joint can create that arch.
Right. If she couldn't, she or he, she I think, if she could not hyperextend the IP joint, she would not need to flex the MP joint so much. Right. So this patient is the perfect example where putting something on the interphalangeal joint may be what the CMC joint needs. Does that make sense? And I don't think, certainly not in my education, I wasn't taught to think that way. I was taught to think only about the CMC. But what we're thinking about now is the loading of the CMC. So if holding the IP joint in slight flexion with something would allow this person to have the arch, maybe you're done. Perfect answer. I paid him, by the way. So I wrote up this little tear test, hoping people would use it in their clinic, and we're going to use it this afternoon and see what we can learn from it. We're looking for an arch when it's loaded. So I'm just going to show you a little video here. Okay, this person is very stable, see? Watch the left thumb, because I've asked her to keep it on the top and not move it. See that arch? That's a really nice, I mean, it's not a perfect arch, but it's a really nice, stable. She's transmitting power, effortless. She could keep tearing, right? It's really nice. Okay, now let's go to the next one. Now watch this gentleman and watch his right thumb. See how he begins to flex the MP and hyperextend the IP? And this lady does the same thing, but she starts that way and she can't tear straight. There you go. See how pronounced that becomes for her and how she struggles. The first lady didn't struggle at all, did she? This is actually me. Look at my right hand. And I get a little bit of an arch there, but I hyperflex my IP. Don't know why. And look how adducted the right thumb is here. She cannot pinch without adducting because she collapses so much. I don't think her thumbnail is that long to create that because she's so loaded that she had very unstable thumbs, yeah. But I agree that if she had a really long one, that she would have to do this. But she wouldn't have to adduct. She would have to hyperextend if she had a long thumbnail. But she tucks her thumb in there for stability because she doesn't have much MP or IP stability. And this is actually a very difficult challenge because the lack of stability in two adjacent joints makes it much more difficult for her.